My name's Wayne Shreffler. I'm the Chief of Pediatric Allergy at Massachusetts General Hospital, and it's my pleasure to talk to you this morning about sort of the second phase of treatment options, those that are in earlier clinical stage or preclinical. Here are my disclosures. So I would like to take this time to provide context for the speakers to follow, and hopefully without any redundancy. We've heard a lot of great talks already in the first day about food allergy pathogenesis. I want to talk a little bit about, sort of perhaps an emerging paradigm around that I hope will be provocative and that I think might inform how we can think about both the natural history and ultimately treatment response, and hopefully can lead to improvements in rational design of therapy. And then I'll briefly review a few examples of early stage therapies, some of which I think have next generation potential or fit into sort of this schema of how we're understanding pathogens. So the entry level vision of allergic pathogenesis is here. It starts with the surveillance of our environment by dendritic cells sensing allergens, but not just the presence of the allergen, but also the context, and that's very important. Furthermore, we now understand, despite the simplicity of the cartoon here, that there's a diversity of dendritic cells that have specialized function and may differentially play important roles in generation of the allergic response versus a homeostatic or regulatory response. But in this context of allergy, this interaction goes wrong and leads to the education of this naive T cell to become a so-called Th2 cell. And now we now also understand that there's really a diversity of phenotypes within this Th2 bucket. But it's subsets of these Th2 cells, one of which we'll talk about briefly to follow, that are effective at providing help to naive B cells that recognize the allergen and then differentiate to produce IgE antibody. And it's IgE, of course, that arms effector cells like mast cells and basophils that, upon subsequent cross-linking with that allergen again, can lead to release of mediators and the symptoms, anaphylaxis ultimately. That's not all these subsets of Th2 cells do. They play important roles in other aspects of allergic inflammation, particularly when there's chronic allergen exposure. Something that we appreciate is probably the case even when patients aren't knowingly ingesting allergen. And it's really this context of exposure that determines, to start, sort of this fate differentiation between making IgE and being so-called sensitized versus having a more normal or homeostatic response to that dietary protein. And the paradigm here is that in the GI tract we get a predominantly regulatory response, whereas in the skin, particularly inflamed skin, we get an allergic response. And that's really been very beautifully demonstrated clinically by the now famous LEAP trial published here by Gideon Lack and his colleagues from London in 2015, which showed a dramatic reduction in peanut allergy as determined by food challenge at age 5 when peanut was introduced in the first year of life to the diet versus what was at the time current practice to continue avoiding until later in life. But the development of IgE, when thought about for a second, in an adaptive standpoint or perspective, is really often in the presence of chronic inflammation, and to be effective in the adaptive ways of either expelling parasites or protecting us from envenomation, or indeed potentially protecting us from toxins or noxious substances in our diet, it depends upon the presence of high affinity IgE. And that doesn't happen in that sort of Patho 101 figure from one antigen interaction event. It rather involves crosstalk between now a growing pool of memory B cells and subsets of T cells that can then further expand and amplify back and forth between each other the pool of B and T lymphocytes that are specific to the allergen or the antigen in a more adaptive context. And again, we can think about these two contexts. On the one hand, the presence of alarmins like IL-33 or TSLP. On the other hand, the presence of healthy gut bacteria and the promotion of regulatory responses as being in competition not only for that initial sensitizing event, but perhaps in an ongoing manner to determine the fate to follow. And again, looking back at the LEAP trial, we now know from this cohort and subsequent work that group has published, as well as confirmation from other studies, including from Corinne Keat in Press Now, that it's the severity of eczema, the presence also of staph colonization, the duration of that exposure and inflammation, particularly or specifically in the absence of concomitant oral exposure, that really drives the allergic immune response. And I would submit that we should think about the allergic state not as a binary state of IgE or not. We know that the presence of IgE, in fact, is not a specific marker of clinical food allergy, but rather this spectrum ranging from healthy non-atopic individuals whose actually antibody response we haven't very well characterized, to those who are sensitized but not clinically allergic upon exposure, to those that are allergic, but even within that group, those that are reactive only at very high doses or with cofactors that reduce the threshold, like exercise or NSAID exposure, to those that are allergic if they ingest hundreds of milligrams or a gram, to those who are allergic even down to exposures of single milligram doses. Also, the persistence of IgE, shown from beautiful work out of the Jordana lab at McMaster, depends upon a population of expanded memory B and CD4 T cells to sustain it over the life of an organism. This is animal model data. And one of the phenotypes within that CD4 population that appears to be key are the so-called TFH13 cells, as discovered by Stephanie Eisenbarth's group, in, again, animal models being absolutely necessary for generating high affinity anaphylactic IgE potential, and confirmed in collaboration with Dr. Barron in this paper in humans as well. And on the T cell work also, or on the T cell side rather, also in work from our own group, we find that differentiating individuals reactive at a low threshold of allergen here on the right versus those reactive only at high levels, that they can be discriminated by the size of their effector memory T cell pool as well. And that's by Bert Rauter in my group in 2020. That concept of immune progression, the need to expand B and T cells in order to become sort of fully clinically allergic and in particular more sensitive to allergy, I think is also seen very nicely going back to that LEAP trial, and is stratified by a particular genetic risk factor that I just want to bring to the fore. First of all, you can see that in the peanut consumption group, as we already know, peanut allergy was strongly suppressed. But in the avoidance group, you see the emergence of this very high titer IgE group of individuals that's very strongly associated with gain-of-function alleles of the gene MALT1. So with an odds ratio of greater than 10, this very, very strong association by GWAS in that population. MALT1 is a really interesting locus because it's an important regulator of NF-kappa B and plays an important role in the duration and strength of B cell and T cell receptor signaling. Not only in peanut allergy, but here in data from the Health Nut study in Australia, evidence that expansion, in this case, those sensitized solely to GAL-D1 in egg versus sensitized to multiple egg allergens, have a worse prognosis of their egg allergy. Again, consistent with this idea that a more progressed or expanded immune response is what underlies the phenotype, the more severe phenotype. And so I propose, this hypothesis to link these phenotypes of persistence, sensitivity, and severity by virtue of immune progression. And that suggests that genetic, epigenetic, or environmental factors determine the propensity to develop this strong and broad adaptive immune response. And that there may be features that are independent of IgE sensitization. And we see examples of this immune progression in other immune-mediated disease, in particular autoimmunity, where we go from clinically silent pathogen-associated immune responses, autoantibodies, for example, in diabetes or rheumatoid arthritis, anti-gliadin antibodies also in celiac disease. And we observe that high-risk populations, for example, first-degree relatives of those with clinical disease, often have detectable antibodies, some of whom will go on to have clinical disease and some who won't, suggesting that there are separate checkpoints that may regulate that progression. In the next slide, how might we understand immune progression then in this context of food allergy and the therapeutic response, and indeed, designing strategies around it? Well, I would suggest that, we already know that higher baseline IgE is inversely associated with treatment outcome. In other words, the higher it is, the less likely that patient is to do as well with immunotherapy. Is this another feature of this expanded or more terminally differentiated phenotype, you might say, along with poor prognosis for natural history, greater sensitivity on a list? We know that unadjuvanted forms of immunotherapy actually initially induce IgE. Might it be beneficial for our patients to specifically blunt or shape that response? So here's some of the data in the next slide supporting the claim that baseline IgE is a bad predictor of treatment outcome from 3 different small oral immunotherapy studies. Not only higher baseline, but possibly a tendency for a higher recall response. I think we sort of see evidence of that. So finally, in the last section of the talk, I'll just mention some of the newer treatment approaches without taking anything from the speakers to follow. So first of all, some biologics, omalizumab and dupilumab. We'll hear from Drs. Wood and I suspect Dr. Maloney more about these trials. I'm putting alternative routes in this category as well. We know from the dual allergen exposure hypothesis that the GI tract is beneficial, but there may be other environments or milieus of presentation, perhaps the skin in the absence of inflammation, intralymphatic, etc. I suspect we'll hear a little bit more about this in the context of epicutaneous immunotherapy in this session as well. Microbiome manipulation, clinical trials underway looking at LGG led by Mimi Tang in Australia. We have a collaborative trial with Vedanta Biosciences looking at a consortium of Clostridia, the rationale being that they promote regulatory responses, and fecal transplant being evaluated in a small clinical trial also here in Boston led by Rima Rashid at Children's. Lastly, other biologics to mention here, mostly in preclinical. There is a vitamin D prevention trial. There are other anti-IgE molecules that are being actively evaluated, or in fact, not only antibodies, but other disruptors of IgE interactions. Anti-IRH2 as a potential therapeutic. And I'll leave you then with this overview of the pathogenesis again, and how we can begin to slot in these various strategies, the anti-IL-4 receptor, for example, blocking not only the early education of naive T cells, but perhaps their subsequent amplification and recall of that memory population that we know is well established in the patients who most need treatment. The possibility of probiotics deviating toward a more regulatory response, anti-IgE obviously disrupting the effector response, etc. And lastly, I look forward to hearing our next speakers, beginning with Dr. Wood to talk about immunomodulatory agents, and I'll rejoin you in the discussion to follow. Thank you for your attention.